So, good morning, ladies and gentlemen. I'm going to be talking a little bit about monitoring and coagulation during surgery and bleeding. My name is Aamer Ahmed. I'm a cardiac anaesthetist in the University Hospitals of Leicester in the UK, and associate professor in cardiovascular sciences in Leicester University as well. So please feel free to contact me if you wish. So really, the problem as clinicians we face is, what do we want to really know? Preoperative assessment. When we first see the patient in the clinic or admission 6 weeks before they're coming for surgery, what we need to think about is, are they going to have a bleeding problem when they come to surgery? If they delay surgery, are they going to have a thrombotic problem? And if you know the likely answer, you can schedule the surgery accordingly in terms of planning when to list them for theatre. Just before you bring them to theatre, if you see them then, the question again is, will he bleed if you take him to surgery, or if he is going to bleed, and if you think the surgery is still an emergency procedure, then you can order platelets and clotting factors, have them ready in advance. And finally, in the post-operative arena, once the patient is back on antiplatelet agents, what you're trying to know is whether or not these platelets are working, because every patient is individual. And indeed, if you know this, you can then monitor the risk of thrombosis and post-operative bleeding. And so the timing of interventions is critically important. This is really an idea of a time frame that I use for my cardiac surgical patients. And so you can see here on the left-hand side, the vitamin K antagonist, and on the right-hand side there, the direct oral anticoagulants. And what we tend to do is, this is taken from the Journal of Cardiothoracic and Vascular Anaesthesia. What we tend to do is we stop vitamin K antagonists 5 days before surgery. And then just after that, we start low molecular weight heparin. And then just the day before surgery, we'd stop that and start 6 hours prior to the intervention, we'd start unfractionated heparin. And then we do the operation, and subsequently, after 12 to 24 hours, when the bleeding is settled down, you can then restart heparin, and then you can restart the warfarin or whichever vitamin K antagonist you want to use, and then finally switch over to a low molecular weight heparin, or keep them on one of these drugs if you want to keep an INR prolonged for a tissue valve or a mechanical valve. On the right-hand side, you can see what we do with DOACs. And DOACs is slightly different because you only need to stop them 48 hours before surgery. And then you can restart the heparin at the same sort of time frame after 24 to 48 hours. So slightly different when to stop them. And it's important to look at the whole hemostatic monitoring pathway, right from the point that the patient is referred for surgery, even from primary care physician, all the way until they leave the hospital. So if you look at this is again taken from the guidelines from IACTA. What we tend to do is, if you look at preoperatively, we should look at optimizing the anemia that patients may have. And almost 20-30% of patients have anemia before they come to surgery. And you can treat them by using oral or IV iron. If you've got enough time, like 6 weeks, to try and get their hemoglobin better. Similarly, non-iron deficiency can be treated by using EPO or iron. And at the same time, we can test fibrinogen levels and platelet function to see whether or not we're likely to need cryoprecipitate or platelets afterwards. The middle section is quite important because this is the bit which is where we work as anaesthetists in the intraoperative arena, which is the maintenance of hemostasis and minimizing bleeding. So we need to have meticulous surgical hemostasis. Nothing can improve upon that, no matter what we do. And then we need to think about the clotting processes itself. So we need to minimize hemodilution. We need to match heparin and protamine titration to neutralize it by getting a low ACT or getting heparin or factor 10A measurements. And the basic things also, which is normothermia, normal pH, so correcting acid-base imbalance and maintaining a warm temperature to stop the patient bleeding. And prevention of fibrin lysis is really important as well, because that is something that takes place under massive blood loss. And using things like tranexamic acid or iprotein or EACA can help. And also within theatres, the use of cell salvage is very useful. Likewise, post-operatively, the treatment of microvascular bleeding often happens. And here, this is where the role of point-of-care tests comes in. So we can use TEGs or ROTEMs or similar devices to monitor bleeding. And I'll talk a little bit more about these algorithms a little bit later on. And similarly, low fibrinogen levels need to be treated with fibrinogen concentrate or cryoprecipitate. Coagulation factors deficiency, predominantly factors 2, 7, 9, and 10, they need to be treated using fresh frozen plasma or prothrombin complex concentrates. And low platelet counts need to be treated using a platelet transfusion. And similarly, we're trying to avoid red cells, depending on whether there's an absolute red cell mass reduction or whether the patient is bleeding out or whether it's a relative hemodilution, depending on how much crystalloid they receive. So what is coagulopathy? Well, coagulopathy, it can be several different ways in terms of the way it presents. It can be intrinsic, and this is something intrinsic to within the patient. So they can come with congenital bleeding disorders like von Willebrand factor deficiency or hemophilias, or thrombocytopenias, factor V Leiden. And all of these things are tested in the lab prior to coming to surgery. Now, that's not something that we can do much about. We can simply measure these individuals' factor assays and then decide to treat if they bleed in theatre because they're intrinsic to the patient and they've been genetically acquired. More often than not, it's what we do as doctors to the patients. So cardiologists in particular are very good at giving antiplatelet agents to patients to try and improve coronary blood flow if they're getting angina. And so we have a load of patients who are on oxygenase inhibitors such as aspirin, and then there are other classes of drugs like the ADP receptor antagonists, of which there are two different types. There's the P2Y12 inhibitors, which work on a phospholipase C and a phosphoinositol triphosphate mechanism, and then there are the thienopyridines, such as the clopidogrels and the prasugrels of the world, and they work in a slightly different manner. And then the third class of drugs are 2B3A inhibitors, such as tirofiban. And all of these drugs cause bleeding because they're quite difficult to reverse if you have to take a patient to surgery quickly. Direct oral anticoagulants are a little bit newer. These are the oxaban group medicines, the rivaroxaban, apixaban, edoxaban, and similarly fondaparinux and anti-10ACE. And these have a similar structure to low molecular weight heparin, but they don't cause hits. The main problem with all of these drugs is that if you give them to 10 different patients who weigh the same, but are of different ethnic origins and different heights and weights, there will be variable penetration of plasma levels. So compliance is an issue, but you can give 10 patients 75 milligrams of clopidogrel and you'll have completely different plasma concentrations within each patient, depending on their phenotype and genotype. So it's quite important to know whether the drugs are working or not. And then finally, there's the acquired bleeding, the acquired coagulopathy that happens after surgery. So it's hemostatic failure because of the product consumption or factor consumption, things like DIC and fibrinolysis. And then post-surgery, you can either get dilution by using lots of crystalloid and colloid, or consumption because of cell salvage and DIC. So there are many agents available for us to treat coagulopathy with. There's desmopressin, which we use for von Willebrand factors deficiency. Tranexamic acid is a cheap and very widely available drug that is used in orthopedic surgery, trauma, and also in cardiothoracic surgery. And then there are the things that we get from the blood bank, the clotting factors, the fresh frozen plasma, cryoprecipitate, pooled platelets, prothrombin complexes, ferritin concentrates, and aprotein as well, which has recently got its license back in Europe and in the UK after having been withdrawn in 2008. And then protamine as well. Protamine is titrated to ACT or the TEG or ROTEM to reverse heparinization. And within the theatre, whilst you're working in the operating room, you can do things such as intraoperative cell salvage, which we will talk about a little bit later, post-surgery reinfusion chest drains. You can get your surgeons to use quality materials such as fibrin glues and Surgicel, BioGlue and fibrin glues. And you should think about using vasopressors if the patient's vasodilated, because a tight and dry circulation is really, really important for clotting to take place. So let's hear a little bit about lab tests. There are many different types of lab tests available, and then I'm going to talk about point-of-care tests in contrast with them. So for the common test, the prothrombin time, which measures the extrinsic and common pathway, and that's designed to measure factors 2, 5, 7, and 10. The activated partial thromboplastin time, the APTT, measures the intrinsic pathway, and that looks at factors 8, 9, and 11. The final common pathway is measured using thrombin time, and then the ratios of the international normalized ratio is effectively the PT for the patient divided by a PT for a standard to give you a ratio of 1 to 1.1. The class fibrinogen measures the lab fibrinogen in the patient, and in more difficult situations, you may need to measure specific factor assays, although it's a little bit more difficult to correlate factor deficiencies with actual patient bleeding. However, there's limitations with lab tests because they require people to do them in the labs. There's manpower costs, and they're not dynamic tests, they're static tests, so they're only representing the results from the time that the sample was sent to the lab. So they're only used for elucidating the cause of unexplained bleeding, and they take a bit of time as well. They take up to 6 minutes to get done to get the result back to the clinician. So these tests were originally designed to monitor vitamin K antagonists such as warfarin and heparin, but they don't give you an idea of what's causing the bleeding. The mechanism of bleeding is still unknown. So, for instance, if you have a prolonged PT or APTT, it could be the result of many different things. It could be a clotting factor deficiency, with fibrinogen deficiency, or hypothermia, hyperfibrinolysis. But the lab test won't tell you what is causing that. The only result will be that it can tell you that this has happened and you've got a prolonged PT or APTT. The tests require additives as well. So the lab test requires citrated plasma samples. And what citrate does is takes away calcium from the clotting cascade. And you've got to fill the tube to its marker. Otherwise, the plasma sample will have too much citrate. And then that, during the test, will mean that the PT and APTT tests are not as accurate as they would be. And this is just a picture I've taken from the UpToDate website to show you what the intrinsic pathway and extrinsic pathway involve, and also the final common pathway, which are the things we were talking about earlier. So what are these tests? So a thromboplastin reagent containing tissue factor, calcium, and phospholipid initiates the extrinsic pathway, as you saw on the previous slide. And that is the basis of the prothrombin time. Similarly, with the APTT test, negatively charged surface such as silica or kaolin is added to the plasma, and that gives a phospholipid extract free of tissue factor. And the thrombin time finally measures the ability of fibrinogen to form strands. So it's looking at exogenous thrombin being added to the warm plasma. That's very, very sensitive if there's any heparin present. Similarly, too much citrate will lead to insufficient calcium being added, and you'll get an artificially prolonged PT and APTT in the lab. If the results are abnormal, then you need to do a mixing test, which I'll talk about in a little bit. And if the mixing test becomes normal, then it was due to factor deficiencies. In contrast, if the presence of inhibitors in the plasma interferes with clotting factors, then the mixing test will not produce the normal clotting results. So we'll show you whether it's due to factor deficiency or not. And this slide really just shows what I was talking about. So the mixing test will be corrected in increased bleeding, but in non-hemostatic problems, it won't. So how do we deal with this? If you've got a patient with an abnormal coagulation defect, the way to investigate them is by looking at, from the lab point of view, doing a PT-INR or doing an APTT. And depending on whether they're prolonged, you can then start thinking about diagnostic pathways as to what's causing the problem. So factor 7 deficiency and liver disease are very common in prolonged INR. And warfarin, of course, will give you prolonged INR as well. Similarly, on the APTT side, if you've got a specific factor deficiency, then mixing study will correct it, whereas APTT will not correct if there's an inhibitor like aspirin. If it's a factor deficiency, it'll correct. If it's a specific inhibitor, it won't correct. And if you've got both prolonged, then you've got to think about why is that? Is there a problem with liver function? And is the liver not producing the factors, the vitamin K dependent clotting factors? Is there a problem with warfarin? Or is there a problem with DIC, for instance, which is disseminated intravascular coagulation, leading to consumption of all the factors that are present in the coagulation process? Going on to the Klaus fibrinogen test in the lab, this is a plasma diluted test done to remove inhibitors of clotting. And then this is then clotted with high concentration of thrombin, and then generates a calibration curve of plasma containing known amounts of fibrinogen to give you an absolute value for the patient. And again here, this is what we'd expect. So in bleeding disorders, if you think about things, you may not get abnormal lab tests at all, or on the other hand, they may be completely deranged, depending on the type of pathology you have. So if you look at the top row, vasculopathies and connective tissue diseases effectively all have normal blood tests, whereas a low platelet count will be present in thrombocytopenia. If you've got qualitative platelet dysfunction, then your platelet count may be normal, but the platelet function will be deranged, which we'll talk about again shortly. And with hemophilia, you get a prolonged APTT, which is a factor 8 deficiency. And again, von Willebrand factor deficiency, you may get normal tests or maybe slightly prolonged APTT, but nothing else. And right at the other extreme, when you've got consumption of everything going on, disseminated intravascular coagulation or DIC, you'll get a low platelet count, you get long PT, long APTT, and a low fibrinogen. So the combination of the test results should guide you as to what is happening within the patient. And there are many causes of prolonged PT or APTT. So you can see, so in the top section, if PT is prolonged, you need to think about factor 7 deficiency as an inherited disorder, or more likely, it's an acquired disorder such as liver disease, the failure to produce vitamin factors, warfarin administration, or lupus anticoagulant. That can cause that. If you look at the second row on the slide, which is here, if an APTT is prolonged, that can be due to specific factor deficiencies of factors 8, 9, and 11, or it can be due to von Willebrand factor deficiency, but more likely it is that you've got heparin on board and or acquired von Willebrand disease, which again is more likely to prolong those things. And if both are prolonged, then it could be inherited deficiency of PT and fibrinogen or factors, or it could be overall liver failure leading to lack of production of liver-generated clotting factors, or DIC and or factor 10A inhibitors. So all of those things must be considered when you've got a prolonged lab test that's in front of you. And this is a sort of algorithm that you can use subsequently to measure on the basis of a prolonged APTT, a normal APTT, or prolonged APTT and PT, how to investigate a patient. And I won't go into great detail here, but it's quite straightforward. It's simply what we've been talking about earlier. So let's move on to point of care tests. They're more interesting because these are things that clinicians can use in the operating theatre. I have TEGs in my own operating theatre complex and in my intensive care unit. And there are different types. So there is the activated clotting time, which we do in cardiac surgery, which is based on a kaolin or C-light based test. And that just measures the time taken for blood to clot. And it normally is about 130 to 140 seconds. And for going on to cardiac bypass after heparization, you need a minimum of 480 seconds or so. There are other systems which are a little bit more clever than that, such as the Medtronic system, which is the HepCon heparin monitoring system. And what this does is builds an individual curve of ACT versus heparin concentration for each patient, because every patient is different. You may give a standard dose of 3 milligrams per kilo to 2 different patients, and you'll get a different level of ACT happening. And what this system aims to do is to try and control that. So it offers predictable dosing. And if you have heparin resistance, it'll offer an algorithm to tell you how much heparin you need to give to the patient to achieve a desired ACT. And the trace looks something like this. So you've got a heparin dose response test. Along the bottom line, you give a little bit more heparin, and along the top line, on the y-axis, you get the ACT. And you can build an individualized curve for each patient, and then decide on the basis of this, if you want to achieve a desired value of, say, an ACT of 500, you need an absolute value of a heparin of X mics per mil, and how much to give. And then we need to monitor what happens. So not just dosing, but also monitoring what's happening. And these are the tests that we currently use. So we've got thromboelastography and platelet function testing. And there are many different companies that make these. Haemonetics is one of them. For platelet function testing in the lab, there's a device called multi-panel, which is, again, based on light transmission geometry. And what that does is it measures the amount of light going through a sample. And depending on the density of the plot, the light will be transmitted less accordingly. That'll give you a value for platelet function. And similarly, the device at the bottom was called the ROTEM, which is more used in Europe rather than the UK. And that, again, is based on the clot formation and the time of the clot formation. I'm going to talk a little bit about that in a minute. And finally, there's a new system called the Hemosonics Quantra that measures clot formation using ultrasound and sound rather than using vibration. So the principles are these. For the TEG, you have a cup, which is labeled here as 2, which rotates, and you have a pin into which the cup sits, and the blood sample is placed in the cup. And as the cup is rotating, as fibrin forms, there is increased friction and traction upon the pin, and that is then translated into a curve that the computer measures. With the ROTEM, it's the same thing. Instead of the cup rotating, the pin rotates, but the cup is static. And with the sonoclot, the pin moves in and out rather than rotating. So the principles are very similar. These devices have been around for a long time. And what happens then is as the pin is rotating, you've got a diode and light is reflected off onto a detector. And as more resistance develops, the pin rotates less and less, and therefore the curve that is drawn changes according to time. The hemasonic system is slightly different. What this uses ultrasound to generate a waveform, and it bounces against the blood sample. As the blood thickens, the time taken for the shear modulus to develop takes longer to come back, and again it draws a curve, which gives rise to a measurement of clot stiffness, and also the time taken to form the clot as well. So you can get an idea of roughly what's happening in terms of how long the clot is taking to develop, how strong it is, and whether or not it's going to break down again. And this is the sort of trace you get on the contra. So you can get here the values of CT and CTH are referring to clotting time using heparin and a plain sample, and the CTR is the ratio of the two. So that's basically 374 divided by 131. On the lower row, you can see clot strength, and clot strength is defined really by the amount of platelet contribution to the clot and amount of fibrinogen contribution to the clot, because those are the two things you require to make a strong clot. And so if you have a low platelet, low fibrinogen concentration, that will lead to clot formation, but your clot strength will be low, and ultimately your clot may break down. And similarly, if your platelet count is low, your platelet function is low, you'll get sufficient fibrinogen binding to make the clot, but the clot again strength again will be down. So you need both components, and these systems will tell you which of the two is deficient, indeed, if at all. The TEG and the ROTEM system is very, very similar. So that if you look at the top half of the screen, which is this part here, the TEG again has a time for the clot to develop, which is known as the R time. And on the ROTEM system, this is known as the clotting time. And similarly, as the clot splits, this is known as the alpha angle, and the rate of rise of this, which is the slope, is important because that is determined by how much fibrinogen is on board within the patient. And then the maximum amplitude reached as the clot splits, or the maximum clot firmness, as they call it in the ROTEM system, is a function of both platelets and fibrinogen. And we'll talk about abnormal traces shortly and what they mean. And if you get fibrinolysis developing, the clot actually can narrow right down here and down to here. And you can see that the clot strength, although it's formed originally, then starts to break down again. And it's all about pattern recognition. So if you look here, this is a normal hemostatic trace, which we're talking about. But then if you have a hemorrhagic patient, you'll have a prolonged R time, you'll have a low alpha angle, and you'll have a lowish sort of amplitude. So this is because of low clotting factors, you have a prolonged R time. If you have low platelet function, the amplitude will be down here. So it's a narrower trace. If you have a low fibrinogen level, the alpha angle will be low, so slow rate of rise here. And if you've got a hypocoagulable state where everything is missing, you'll have a combination of prolonged R time, alpha angle, and a low MA. Similarly, if you're very thrombotic, which is something we don't see very often, but you can get a hypercoagulable picture. You can get a short R time, very steep rise in clot strength, and a persistent clot strength all the way through. And these are rarer to see, but nevertheless, they indicate that probably you've got too much clot on board and there's a risk for thrombosis rather than bleeding. And finally, looking at this, if you take fibrinolysis taking place, you get initial clot formation that is good, and then you find that the clot breaks down and the fibrinolytic system is overactivated, leads to clot production. And this is the same thing with the ROTEM, as I was talking about. They call it the clotting time for the time that's known as the R time. The rate of rise is the alpha angle, and these points, the A5 is the deflection at 5 minutes. The maximum clot firmness is the maximum deflection. And then if you get thrombolysis developing, this is known as the lysis 30 index as the clot strength goes down. And then the basis of all these tests is that you can then develop an algorithm to decide how to treat your patient. So if you think about what is happening to the patient, if you've got a factor deficiency, what you want to do is not treat the factor deficiency by giving platelets or fibrinogen. You need to treat it by giving additional clotting factors. And so you can decide to treat on the basis of that by giving additional fresh frozen plasma rather than inappropriate treatment with crash pack containing everything else. Similarly, if you have a patient that's got a low clot strength because of the maximum firmness being down, you will need to give them platelets, and you may need to give them additional fibrinogen as well if you find that the alpha angle is low. So depending on the nature and the shape of the curve and the values, you can decide whether you need to treat with factors or fibrinogen or platelets or a combination of all three. And so this is the sort of trace you get. This is a normal patient trace on a ROTEM system. You've got a normal R time, normal deflection, normal alpha angle, and a normal amount of fibrinogen present in the fibrin test here. As soon as you get platelet deficiency, this starts to happen. So the fibrinogen is normal, but the maximum amplitude reduced. So the amplitude here, the maximum clot firmness, is much narrower than it was on the previous trace, as you can see. So in this case, you need to give platelets to treat the patient. If you've got a pure fibrinogen deficiency, you're going to get the angle and the rate will probably be a little bit lower, but it'll get to eventually where it wants to be. But you'll notice that the fibrinogen is low, and this is the sort of patient you need to treat with cryoprecipitate or 2 or 4 grams of fibrinogen concentrate. If you've got fibrinolysis taking place, this is the same thing we saw earlier. You get clot formation, but then that clot dissolves away again. And the treatment for this is using tranexamic acid or aprotinin, which is both antifibrinolytic agents. If you have the influence of residual heparin left, so you've done your cardiac surgery, you've given heparin, you've given protamine at the end of it, and you've still got a little bit of heparin left, it will present itself by showing as a prolonged R time on the heparinase test. So when you give heparinase in the sample, that R time will normalize. So what this tells you is that there's excess heparin present, and the treatment for this is giving additional protamine back to the patient. Here you can see the fibrinogen is also down a little bit, so you might need to give a little bit of fibrinogen as well as giving protamine. And so this is sort of algorithms we can generate. So this is a ROTEM algorithm saying, depending on the defect, whether the clotting time is prolonged or whether the MCF is prolonged or whether there is a difference in the MCF and the clotting time together, you can then decide how to treat. So the basic things that we talk about are treating are obviously treat the hemoglobin, so treat anemia if you've got it, treat calcium, treat acid base, make sure the temperature is good and make sure there's no surgical bleeding. But beyond that, then we then start to think about factor deficiencies and treatment using fresh frozen plasma, whether it's a heparin effect and you need to give more protamine, or whether you need to give additional cryoprecipitate or fibrinogen concentration, or perhaps platelet transfusions, or if it's a combination of all of them. And this is based on the INTEM and EXTEM. This is the algorithm I use in my hospital, which I devised, which is based on the thromboelastograph, the TEG. And here it is the same sort of thing. You look at the R time, you look at the maximum amplitude, you look at the clots, lysis time, and then you, depending on how prolonged they are, we treat according to the basis of whether they are very, very prolonged or deranged, or whether they're only slightly deranged. And then these are the doses we use. So we use fresh frozen plasma, we use platelet transfusions, we use cryoprecipitate or fibrinogen concentration, and then also you need to think about tranexamic acid if you've got fibrinolysis taking place. And then in addition to that, if you've got platelet dysfunction, rather than platelet numerically being low, then you need to check platelet function tests. And you see these here. So if you run a multiplate test, for instance, if the result is greater than 50 units, then the platelet function is okay. If your platelet function is down, you're going to need to give them platelet transfusions if the patient's bleeding. But if it's really, really down, you should probably give the platelets irrespective, no matter what, if the patient's bleeding or not. It's important to look at the evidence of guidelines because there's so much information out there and everybody produces different sorts of information. These are just 4 guidelines that I've shown you recently. They've been produced, the EACTA guideline and the EACS guideline for patient management and cardiac surgery. But for every type of surgery, European Society of Anaesthesia produced the severe perioperative bleeding guidelines, and this has been updated once already in 2017, and it's about to be updated again shortly in the next year or 2. And I've been lucky enough to be involved as one of the authors for this. Similarly, in the UK, the Association of Anaesthetists produced some guidelines on the use of blood components and the alternatives. And all of them fundamentally rely on the same sort of idea that you don't treat blindly, you treat the patient on the basis of the evidence in front of you. So do some tests, look at what is deficient, and then treat the deficiency, rather than treating everybody in the same way. This is the bleeding algorithm they use in cardiac surgery at Duke University. And there, I think what is similar to what we are starting to do in my clinical practice for aortic surgery is the earlier use of using prothrombin complex concentrate. So the big decision we have at the moment, both in major trauma bleeding, but also in cardiac surgery and aortic surgery, is do we use large amounts of blood bank products such as fresh frozen plasma, cryoprecipitate, and platelet transfusions, or should we use some of the freeze-dried drugs that we've got, such as fibrinogen concentrate, prothrombin complex concentrates, and so on. And increasingly, the evidence is getting more and more strong that if you have a patient that requires a high dose of concentrated factors, you should start to use PCCs and Fibrinogen concentrate rather than transfusing them with large volumes of red cell products. Because if you imagine you've got a patient that needs 4 units of fresh frozen plasma and 2 units of cryoprecipitate and 2 units of platelets, the amount of volume you're going to give that patient is going to be nearly 1,1600 mils. And sometimes patients are not able to accept that amount of volume. So if you've got a patient with severe right ventricular failure or a patient who's got a poor ejection fraction, they're not going to be able to accommodate that much volume because the heart will start to fail. And so in that sort of patient, you may be better off giving them prothrombin complex concentrates in the doses of between 10 and 15 units per kilo, or a Fibrinogen concentrate in doses of 2 to 4 grams to try and give a small volume but a higher concentration. And that's increasingly where the thinking is going. On the other hand, it may be the other way. So if your patient has got space in their circulation and they're hypovolemic and they need volume resuscitation as well as clotting factors, then the correct choice would be to give them the clotting factors from the lab rather than the freeze-dried ones that we're talking about. So summary, really, overall, what I want to say is that it's important to treat the surgical cause. We've talked about lots of issues about monitoring coagulation and how to monitor it, but the reality is if the bleeding is persistent and it's not stopped, you need a surgeon to deal with it. No matter how much clotting factors you give, if the patient is bleeding out, you're not going to deal with it. And in different types of surgery, it's important to anticipate the coagulopathy and treat early. So think what may happen. The 4 major arenas where this happens are trauma surgery, hepatobiliary surgery, obstetric, massive obstetric bleeding, and in cardiovascular and thoracic surgery as well. So anticipate those groups. Think about what products you might need. Liaise with your blood bank early, and have to be on a good relationship with your hematologist because they're the ones who let you have the products. It's important to measure what you can measure and treat appropriately. So the days of treating things with crash packs are probably gone. I think it's important to look at what is deranged and treat on the basis of what's deranged, and then measure again. So if you're still requiring more therapy, you can treat with a second round of products if need be. And you've got to remember that clot strength is dependent on 2 different factors, not only platelets and platelet function, but fibrinogen as well. So it's important to treat both aspects. You can have a clot strength that looks good on paper, but in fact, it won't be very good and the patient will start bleeding again because you're either deficient in fibrinogen or you're deficient in platelets. And you need to have both present. So use point-of-care tests, be guided by labs as well, because the labs can give you specific tests that the point-of-care tests can't. And correct the basics, as I said earlier. It's correct calcium, correct hemodilution, because plasma viscosity is important. Correct acid base, because again, your enzyme systems and your clotting factors will not work very well if you're very, very acidic or very, very alkaline. And correct temperature, because again, temperature, as you cool down, your enzyme systems slow down as well, so your clotting cascade can't work very well. The classic situation arises, you've got a patient that is bleeding, the patient arrives in the intensive care unit or in the operating theatre, they're still bleeding. You give them large amounts of crystalloid and colloid resuscitation, such as Glenfield or Volplex or Hartmann solution. You're not running it through a blood warmer, so the patient cools down. And as the patient cools down to below 35 degrees, then their enzyme systems start to fail and start to work more slowly. And hemodilution starts to take place, so that if the hemoglobin drops to below 8 grams, then the plasma viscosity will go down, and therefore it'll be more difficult for clot to form, and then they become more acidotic as end organ perfusion starts to fail. And the treatment for all of that is to treat in the sequence. So repeat the measurements, repeat bleeding and coagulation, because remember, what was a value half an hour ago or an hour ago will not be the value that is presently present, because it's a dynamic situation. And try and use cell salvage. It's important to remember that cell salvage devices are very useful, but what they generate is a high hematocrit, so almost 66%. In the washed red cells, but not only do they wash red cells, they wash out heparin, they wash out clotting factors as well. So if you're going to give a large amount of cell-saved blood back to a patient, you need to give additional clotting factors back to the patient as well. And sometimes we kind of forget that, and it's something to think about. So that's really what I want to say. I hope that's given you an overview of hemostasis, both in the lab and point of care, and also where we are in terms of coagulopathy and coagulation management. Thank you very much indeed.